So you're gonna have, because you're having traffic jams in two different parts of the body, you're gonna have different results, right? Or effects. That makes sense, right? Structures related to function, damage a certain structure, you're gonna damage a certain function. Make sense? All right. I want everyone to lift up their left hand like as if you're gonna say, I solemnly swear. Yeah, lift it up, don't be scared. All right. And when you do that, I want you to say pink puffers.
Pink puffers.
Touch the left side of your chest. Pink puffers. Right side. Lift up your right hand. Blue bloaters.
Blue bloaters.
Pink puffers.
Pink puffers.
Blue bloaters. All right. So what do you think the pink puffers for? That's the left side of heart failure, pink frothy sputum. Okay. So for these people, Lasix they're definitely going to get because they have fluid, tons of fluid on board, but it's in their lungs. Okay. But we also want to pull the fluid out and maximize the fluid, the blood going to the body. So Dig and Lasix are not uncommon for these guys. Okay. For the blue bloaters, what do you think I'm definitely getting with that bloating? What kind of med? Say it louder. Yeah. Yeah. Absolutely getting a diuretic. Because these people, while you're seeing jugular vein distension, you're seeing vein distension everywhere. Remember, when you have edema that you can't see, you have edema. When you have edema that you can see, there's always edema that you can't see. So these people, not only do they have jugular vein distension and blood backing up to their brain, they've got blood backing up to their kidneys, blood backing up to their liver. They're going to end up with hepatomegaly, all of these megalies. They're going to have maybe ascites in the abdomen because the fluid can't move forward. So then these people are going to, in addition to feeling like this, they're going to feel nauseous and bloat. See how all that makes sense? So to get rid of that fluid, it's one of the quick fixes because you're not fixing the actual problem. It's just a Band-Aid is Lasix. Okay. They may also, depending on the type of heart failure they have, y'all can say, of course, they may need to take a beta blocker. Not uncommon for them to take metoprolol. All right, folks. Now, the toughest thing that I talked about is heart failure and DIG. I may not have a whole lot of this in these slides, and the reason being is it's kind of hard to put it in here. All right. But the way that I taught this to you, we'll be able to understand everything else. So I'm going to skip over some stuff. If it's not necessary, I feel for me to go over, I'm going to skip over it. How about my thingamajiggies? Oh, here they are. These things don't even need spray. I thought she was kidding. I like stuff like this. All right. Get rid of some more things. All right. All right, so we're going to use some words here, perfusion and ventilation. This actually ties into respiratory, so I'll talk more about that later on, okay? The stuff I'm going to zero in on is what I want us to zero in on. In order for ventilation and diffusion, that's nothing more than the crossing over of gases past the membrane. So that's your capillary bed exchange. We've been talking about dropping off oxygen, picking up CO2, okay? That's considered to be, your capillary bed exchange is considered to be diffusion. You also need, in order for effective perfusion, an intact pulmonary circulation. That's why those two things go together. That's why they say cardiopulmonary. They go together. In order for this to happen, those two things do work together. And that's why you have CPR, right? Cardiopulmonary resuscitation. Does that make sense? You also, in order to have perfusion, you need to have enough blood. That makes sense, right? Okay. Because if I don't have enough blood, then I can't get the blood to the tissues. Does that make sense? Yes? Now, maybe I have enough blood, but what if I can't get the blood to the tissue because I don't have enough of a pump? Like with my left-sided heart failure. Maybe my cardiac output is down. If I have a decreased amount of blood coming out of my heart, pumping to the body, I don't have enough. If I can't get the blood to the tissue, then my perfusion is affected negatively. Does that make sense? I don't hear anything.
Yes.
Okay, all right, good. I just want to make sure it still makes sense. All right, additionally, your receptors, as you know, are lock and key. That needs to be there. All right, so some of this is not showing up on my slide, but it's showing up on y'all's. It's weird. Let me try it again. Zoom slideshow. This is weird. Let's try it again. Okay, let me see. So of course you need your nervous system intact because that controls everything, especially my pacemaker of my heart to beat faster or slower, which is, y'all remember where that is? SA node. You remember what the rate is by any chance? How many times a minute?
60 to 100.
60 to 100. Cool. So that makes sense that needs to be intact in order for my heart to beat the right amount of times. My whole circulation, all that over there needs to be intact, because if it's not, you can see how that's going to affect it. When we say the cardiac, they're talking about the heart. Coronary, they're talking about the actual arteries that are coming around. Same concept. If I have blockages to my coronary arteries, I'm not going to get blood to my heart tissue, and then that muscle, it becomes ischemic, and if it loses oxygen, becomes ischemic. What comes next? Necrosis, which is tissue death. Dead meat don't beat. So if it's not beaten, then it's not going to meet the oxygen demands of my body. Okay? And then here's the thing. I can do all of that stuff. I can have that intact. I can have enough blood. My nervous system's maybe working. I can pump out the right amount of blood that needs to happen. However, if my tissues do not take up enough oxygen, that's still going to compromise my tissue perfusion. Well, why would somebody's asking it, someone's thinking, why would your tissues not want it? If it's there, it's available, why wouldn't they? There's some disease states, such as sepsis, right? Or if your body goes into any sort of acidotic state, when your cells become like that, they can't. Yeah.
So does that affect receptors, and that's why they don't want to take it?
It's actually not the receptors themselves that are affected, but the receptors are not going to receive it. It's more so that the cells are, it depends on what's going on. So like in sepsis, I like to talk about sepsis because you'll see that when you do your patient's ADG, their oxygen levels through the roof on the ADG. And you're like, but I'm giving them enough oxygen. Why is it still so high in the arterial side? Your arterial oxygen shouldn't be so high. But why is it so high? Because your cells aren't picking it up, because that patient's in such a septic, dysfunctional, acidotic state, it's just not able to pick it up. It doesn't mean that it's the receptors, it's just the cells. It's what the acid is doing to the cell as a whole.
So you're just jacked up so bad that your body doesn't want to help itself.
It can't. You know, when you're so sick and, you may need to eat, but you can't.
Yeah.
You may need to go have water, but you just can't do it. It's kind of like that. That's why sepsis oftentimes leads to death. I can give you I can do all of this, but depending on how bad you are, I can't help.
So the only reversal is through medication?
For
To make your
sepsis
body
or for decreased perfusion. For sepsis,
Sure. Yes.
well, you have three phases. I'm going to digress for a moment. You have 3 phases of sepsis. First 2 you can recover from. That third phase of sepsis, depending on how long you're in it, you're not recovering. Your other organs start shutting down, and this is why. Because your tissues shut down.
Mm-hmm.
So you have what's called MODS, multi-organ dysfunctional syndrome. All your organs shut down. And it's just because of what that toxin is doing. This mess. All right, so BQ perfusion, without throwing a whole bunch of numbers at you, they're just talking about ventilation. It's talking about take a deep breath in and exhale. Do it. And exhale. You've just ventilated. When we put someone on a ventilator, It inhales for them and exhales for them. Make sense? That's all it is. But just because you're ventilating doesn't mean that your body is perfusing. Doesn't mean your body's getting the oxygen to its tissues. No. That's like saying because I have a heartbeat on my monitor, my patient's, or I have a EKG tracing on the monitor that my patient's heart's beating. That's not the case. You can be breathing in and exhaling, but that oxygen is not diffusing and getting to your tissues. That's everything we just talked about. Okay? If that ever happens, we call that a mismatch, VQ mismatch. Okay? So here's an example. Look here. There's many examples of how that can happen. But here, what they have is perfusion without ventilation. So in this case, you've got your capillary beds going on here. Carbon dioxide's coming out here, but because it's not being met by oxygen, carbon dioxide continues to diffuse right on across. There's no gas exchange because there's no ventilation of oxygen. You see that first example? Look at the second example. I've got carbon dioxide that comes out and it's met with the oxygen that you inhaled. Anthony, you so beautifully told me this story, and this is exactly what took place there at the capillary bed. So in order for me to have perfusion, I must have ventilation, but just because I have ventilation does not mean I'm perfusing. Does that make sense? Yeah.
Can you
Makes
repeat
sense.
one more time?
In order for me to have true perfusion of oxygen, that swapping of oxygen, CO2, okay? In order for me to have true perfusion, I must have ventilation, meaning you must inhale and exhale. If you hold your breath, you are not going to be having a gas exchange of carbon dioxide and oxygen. You're just going to have carbon dioxide continue to build up, and it's going to go from 35 to 45 to 70, and then you become respiratory acidotic. Yes?
Mm-hmm.
Okay. Aha. But as soon as that level gets too high, that's your trigger. All of a sudden you exhale and you blow out CO2, which is ventilation. Now you inhale and you exhale. As you inhale that oxygen is allowed to now diffuse and get to your tissues. And as you exhale, that CO2 is allowed to diffuse and come out of your body. So in order for perfusion to occur, you must have ventilation. Does that make sense? It won't happen without it. But just because you are ventilating does not mean you're automatically perfusing. There could be some sort of a blockage at some sort of a level. All right, so we know about this, coronary circulation. We took our time to learn it. Well, the cardiac circulation. And I'm not going to make you know all these, I promise. Maybe in another class you will. I actually didn't have to learn this until my advanced master's courses. But what this is showing you is, if you look here, that is, when we look at the heart straight at our patient, that's the way we would see it. If we were standing behind our patient on the bottom, that's the way we'd see it. So the first one's anterior view. Second one is posterior view. Can you see all these vessels? She didn't do a bad job with the big old heart and the vessels. Look, she didn't. She didn't do a bad job, okay? You see how the superior and inferior vena cava meet together at that right atrium, right? And you see how that pulmonary artery branches out and the aorta branches up, and you see how those coronary arteries and veins branch off of those major vessels. That's how they feed the heart, okay? You can also see that because they're kind of tiny, if you eat a whole lot of fried chicken and fatty foods on a regular basis, plus have high blood pressure, one of those bad boys can get blocked. And if it gets blocked, look at where they terminate. Look at where they end. That's where blood flows. If it gets blocked, blood's not flowing there. Does that make sense? So if you have a blockage high up, like kind of like where that right atrium is or the left atrium, you can see how that could completely cause you to die. Like drop dead die. Because that's a whole portion of your heart that's not getting any blood flow. Do you see it? Mhm. So when someone has an MI, that's what's happening, myocardial infarction. That's literally what's happening. What's a recipe for a myocardial infarction? Two things. I told it to you, but I gave it to you in a scenario. There's two things for a heart attack, and it's a big deal. Blockage. Well, what do you think the blockage can come from? Often, most times, embolus, and more specifically, someone said plaque. You're eating the fatty foods? Yeah, so hyperlipidemia. And then I need something that's going to cause that blood vessel to not just come down around that plaque, but also increase the pressure behind that plaque to dislodge it. What does that? Hypertension. Hypertension plus hyperlipidemia are a recipe for a MI and a stroke. Textbook, and it makes sense. It makes sense. That's the reason why we need to get that blood pressure down, and we need to give your patient a statin. We got to get those lipid levels low.